let's take a look in the future. Because it sounds to me as if these are exciting drugs. And whenever I hear about exciting drugs, there's more exciting drugs coming, because once you see some effect and some acceptance of these things, everybody wants to get better. So what is on the horizon? What are the emerging drugs for the treatment and management of schizophrenic patients? Programs, drugs, anything. Now the field is wide open. Why don't you educate?
Well, I would go back to a point that I've made before, that the drugs that we have available in psychiatry they only treat symptoms, they don't cure. But I am hopeful that within our lifetime we will have a more personalized medicine. Like cancers, no. Cancer was not there 10, 15 years ago, but now you make the diagnosis and you treat and you select the right medication, individualizing for patient. I think in psychiatry we're going to be there at some point. We're not there yet, but that's the way to go.
What's in the pipeline that you know about right now?
As far as programs, I think we've spoken about some of those cutting edge programs that are occurring in Cook County and Miami-Dade that other correctional institutions and community mental health providers should take a look at, because those are model programs that we've already shown effective.
What's the problem? It sounds like you've got a program in Dade County that's actually working. It's not perfect, you've said so, but it's working better than in many other communities, and you've got a program. Why doesn't everybody say, whoa, look at this stuff? It's cheaper, it's better, let's just do it.
Scaling's hard. You need political willpower, you need leadership, you need resources. And we're getting there. On an airplane too often now, trying to teach other communities how to do this, but we have a long way to go.
But you say you need resources. These programs not only self-fund, right? They actually generate surplus income that you can put
They do, but
elsewhere.
they're out of different pockets.
Oh, it's a silo issue.
It is a silo issue. And so,
I hate silo
issues. Corrections doesn't want to give up their money to give it to the community mental health system, and so it requires a lot of collaboration.
Oh my goodness. Is that what you see too?
Yes, absolutely. We have to break the silos, and until we break the silos, then we won't get to that point where we can say that people with mental illness are being effectively treated in the community.
By the way, that's not just a mental illness issue, and it's not just a correctional issue. I've seen it in hospitals everywhere. We save money on the pharmacy budget, but that's okay. But I don't see the profit. I don't see the difference. So over here in the operational area, we're not going to do it.
I am optimistic, though. We created this national initiative called the Judges Psychiatric Leadership Initiative, and it's judges and psychiatrists. And what we're finding is judges are really at a wonderful point, because when we invite people to a meeting, they come, whether they want to be there or not.
Is that because you can say you're going to JPL?
They worry about that.
Great pictures.
Contempt is a beautiful
It's always
thing.
good to be friends with a judge.
And so, what we have to do is, and we're encouraging judges now to get the right people at the table, start to map out the intersection between criminal justice and mental health, develop written collaborative agreements that actually make this structural change, look at the best practices that are out there, and implement them. And that's what we're trying to do, and we're moving in that direction.
But I sense there's a glacial progress here, that there are some really aggressive communities, and then the rest are sort of like, well, I don't know. We've always done it this way.
But I see a change.
You do?
Oh, significant. I really do. And I think in the next 10 years, hopefully as the medications continue to improve and become more accessible, we cannot afford to continue to do it the way we're doing it. It's too expensive. It's terrible outcomes, and people have finally started to understand.
I don't want to leave without looking at pharmacology again. What's in the pipeline coming down the pipes right now?
Well, generally in the pipeline is to look at beyond what we have as a dopamine theory of schizophrenia, just blocking dopamine or dopamine modulation. So looking at a variety of other receptor types that affect schizophrenia, not only positive, what we call hallucinations, delusions, but what we call cognitive functioning. It's really a cognitive disorder. It's a brain disorder as well as other parts of the body. And it's also what we call negative symptoms, this lack of initiative to maintain functioning. So the agents are really looking at a variety of different receptors, either as adjunct to what we usually use, or may replace. We had the first non-dopaminergic agent that was actually now approved for psychosis and Parkinsonism. So it's not necessarily in general psychosis, but we're moving to see other agents.
So what struck me at the very beginning that I did not really understand, or just didn't know, was that schizophrenics suffer brain degeneration. And then you told me that if you treat it, you can slow this or eliminate this.
Well, I don't know that we can, there's mixed data on
I
the
wish
actual
that were
brain
true.
degeneration, but
wish
we
that was true.
can look at changing levels. Every time you have a psychotic episode, you deteriorate and you may bounce up a bit. With each episode, you seem not to bounce up quite as quickly or to where your previous level was. So if we could reduce the number of psychotic episodes, the goal is, and we've been able to see that, you could hopefully maintain a level of functioning for a longer period of time.
That does suggest, however, that there is some biological deterioration. The question is, can we prevent it by preventing recurrence?
Absolutely, and actually, moving to bipolar disorder, it is clear that having relapses, not only the patient has the consequences of the relapse itself, actually the condition becomes more chronic, as a colleague mentioned. So it is important to prevent those
And the same with
relapses.
schizophrenia.
That's a powerful argument for maintaining a smooth,
Absolutely.
continuous therapeutic milieu,
Absolutely.
as opposed to episodic treatment.
And not changing the medication if it's working.
You know, my mom told me this: if it ain't broke, don't fix it.
But actually, medications won't do it by themselves.
Okay.
We need a better system to treat our patients.
And with